In terms of genetic testing and biomarker testing, so most testing is still being done on tumor samples. The UK has been relatively slow to take up liquid biopsies, although that's getting better and increasing, as I'll explain. And so in general, it's done according to tests in the test directory that lead to treatment, potential treatment options. And the number of treatment options that we have now available in lung cancer has increased very, very quickly. So, up to a few years ago, it was just EGFR and ALK. And those were relatively small proportions of the patient population, particularly if you work somewhere like I do in the northeast of England, where a lot of lung cancer is related to previous exposure to smoking and industrial carcinogens. So, our rate of EGFR lung cancer is about 7%. And then you add in ALK and it's another 2 or 3%. So that was only 10% of the population. What we have now is, we've first had ROS1 inhibitors coming through, NTRK inhibitors. We've recently got the approval for the RET inhibitors as well. And each of these are very small proportions of the population, but they start to add up. And we've got MET exon 14 skip lesion inhibitors coming through. So MET inhibitors for that patient group is coming through. The one that's made a big difference in terms of the proportion of the patients is the recent approval of the KRAS G12C inhibitors. So there's a couple of them, but in the NHS, we presently have access to sotatercept, which was the first one. And that's a big proportion of a patient population. So in my practice, it's about 12 or 13% of patients will have KRAS G12C. So that's almost doubling the number of patients where you can offer them a sort of precision medicine treatment at some point in their cancer journey. And so, you can add these up, and I reckon it's somewhere between 25 or 30% that will have access to a oral precision therapy, if that's what targeted therapy, if that's what you want to call it. And then, of course, we've got the immunotherapies as well. You've got your high PDL1s, which is another 20 or 30%, although some of that will overlap. So yeah, compared to where we were in 2013, it's a bit where we were just giving platinum doublet chemotherapy to all patients with lung cancers. It's a bit different. In terms of liquid biopsy, I think it's increasingly recognized in guidelines that this can give us additional information for the care of our patients, and probably in an ideal world, we would be looking at both tumor analysis and liquid analysis, and potentially serial liquid analysis further down the line. Realistically, at the moment, I don't think in the national healthcare system we can afford that. So we then have to think about what the optimum place might be for the lung cancer for the liquid biopsy analysis. And to me, it has a few roles. So number one is, at the moment, we have patients who are, because of the delays in diagnosis with COVID, and getting biopsies, we have a number of delays in the diagnostic pathway, and patients are coming through with a poorer performance status. And it's more difficult and more expensive to treat them because they're more challenging to treat. So if we can identify early on those patients, then that might be a good use of resource. And so that's something we're looking at in the northeast of England at the moment, is going for a very early liquid biopsy, so circulating free DNA analysis, blood draw, at the time when patients are first presenting to the respiratory physicians. We're going to try looking at this anyway, and to see whether that speeds their pathway, increases treatment rates, and is actually a cost-effective use of resources. And then the other times when I think it can be useful is in patients where you can't biopsy, where you're going for serial biopsies to try and get sufficient tumor for molecular analysis. And then lastly, the patients who are progressing on targeted treatment, where you may be able to identify a new treatment for them on, based on their molecular resistance or potentially a clinical trial. We're doing a lot of circulating free DNA work in patients referred through for clinical trials.